When looking for pleural effusion in longitudinal view, according to radiologist convention, the index marker is directed toward the head in longitudinal view, and the marker is on the right of the screen. Liver and spleen appear at the right of the screen of the echograph. In transverse view, the marker is directed toward the left side of the patient. The image corresponds to the CT view. At the lung interface, the air-soft tissue interface acts as an acoustic mirror, producing a mirror image of the liver. High-intensity reflected sound is reflected several times within the liver or spleen, prolonging the time of return of echoes to the transducer. Prolonged time of flight is interpreted as being deeper in tissue. Thus, images of the liver or spleen are displayed above as well as below the diaphragm. Mirror image artifact occurs only when air-filled lung is present above the diaphragm. Thus, mirror image artifact of the liver and spleen above the diaphragm should be considered normal. When pleural effusion is present, or when the lower lobes of the lung are consolidated, sound penetrates the diaphragm and lung or fluid. This video shows examples of lung bases in absence of pleural effusion in longitudinal views. Note the grayish appearance of the supradiaphragmatic zone pointed by the arrows. Visible through the dorsal part of the right lobe of the liver, B-lines evoke a sunrise. In the presence of this sign, interstitial disease of the right lower lobe should be suspected. The presence of these lines also exclude the presence of pleural effusion on that side. When an effusion is present, as in the right side, it appears like an anachogenic zone between the lung, chest wall, and diaphragm with regular limits and variable echo structure. Sometimes the mirror image can be tricky to identify. In this case, there is another way to identify pleural fluid, which is known as the spine sign. This sign makes use of sound's ability to travel through the fluid instead of being scattered by air. The spinous processes, our vertebral bodies, are deep to the kidney and spleen or liver when looking from the mid-axillary probe position. When the thoracic cavity is full of air, as the diaphragm expands, it pulls caudally to aerate the lung. The shadow from the lung will cover the spine shadows above the diaphragm. When the thoracic cavity is full of fluid, sound can travel through the thoracic cavity to the thoracic spine, and so the spine shadows are seen throughout. The more reliable sign for diagnosing a pleural effusion is dynamic. The collection thickness varies in rhythm with the respiratory cycle. The deeper border moves towards the chest, thus shaping a sinusoid, whereas the superficial border, which designates the pleural line, is motionless. The fluid color sign refers to the presence of color Doppler signal within the fluid collection that is generated by transmitted respiratory and cardiac movements. The fluid color sign is demonstrable in pleural effusions, but is absent in pleural thickening. Remember that to demonstrate this sign, the sensitivity of the Doppler should be set to a low velocity scale, typically 0.15 to 0.30 milliseconds.